Hello and welcome listeners to the MLCC podcast. This podcast is hosted by Medical and Life Care Consulting Services, a case management and nurse consulting firm headquartered in Massachusetts. We are excited to be joined today by Kerry Skillen and Dr. Sean Rockett. Kerry is a nationally recognized vocational consultant and expert witness with more than 30 years of experience in vocational consulting, vocational rehabilitation consulting, and vocational expert work. At MLCC, she specializes in assessing employability, wage earning capacity, job search diligence in cases involving personal injury, medical malpractice, employment law, family law and divorce, workers' compensation, and LTD. Dr. Sean Rockett, specializing in orthopedic surgery, has been with Orthopedics New England since 1999 and is a senior partner. Dr. Rockett received his Bachelor of Arts in Biology from Harvard University and completed his medical degree at Tufts University School of Medicine. He interned in general surgery from Tufts Medical Center, where he also finished his residency in orthopedic surgery. The topic of today's episode is return to work considerations, perspectives from physicians and vocational consultants. Kerry and Dr. Rockett will discuss various topics on work readiness, the meaning behind restrictions, medical opinions on work capacity, vocational rehabilitation, and medical checklists. Thank you both for joining us today. And now here's Kerry Skillen to kick us off.
Thanks, Amanda, for that. And thank you, Dr. Rockett, for being here today and helping us learn more about the physician's perspective, too, about return to work considerations. Excellent. One of the things that I'm always curious, my role of helping injured workers get back to work, and even from the legal perspective of understanding restrictions, is what goes through the minds of doctors. So when you're meeting with patients, especially in that post-op period, and that patient is coming into you and maybe they're approaching MMI, maybe not there yet. What are some of your thoughts as a physician that you want to see that patient demonstrate so that you feel comfortable releasing that patient back to work? What do you look for?
Yeah, I think it depends on which body part we're talking about. You know, I do a lot of shoulders, knees, and hips. And so I would sort of target, say if I was looking at a shoulder, how is that person's pain, how is their range of motion, and how is their strength? And that's something I can get a good sense of in the visit and under a physical exam. I like to hear what is going on at therapy, and you know, really the simplest question is how's your shoulder doing? You know, how are you doing? How's your shoulder doing? And if right off the bat somebody will say, you know, oh, I haven't gotten out of the house and I'm watching TV all day, and you know that's a red flag, you know. So things like just how are they functioning? How are they, you know, usually I will have incorporated some form of light duty at some point in their shoulder rehab. How is light duty going? Do you feel good? Do you feel like you can advance? So it is a lot of give and take in that office visit. And if a case manager is there, also hearing what they have to say, you know, did the patient not go to 10 out of 12 physical therapy visits? You know, that's also helpful information. So I think it's just talking to the patient, getting a good assessment for how comfortable they feel moving forward, and hopefully everything is going well. You know, sometimes there are post-op glitches and people have swelling or scar tissue or tightness, or you know, just getting an overall sense of where the patient is and trying to find out, is there something that they can be doing at work that will keep them in the action while they're recovering.
Well, that makes sense to me too. And what about functional capacity evaluations? Do you ever either refer patients or recommend them or see them? And what do you use or rely on in those evaluations?
Yeah, I will use them. If everything's going fine and somebody says, I feel great and I'm lifting 100 pounds at work and had no issues whatsoever, and I'm examining them and I can feel them and get a good sense of their strength. And it's sort of, if everything is going well, I don't use them. And if things are not going well, and it's sort of, we're at a time period where there's nothing structural that I'm detecting, or say there's even a repeat MRI showing the repairs intact, and usually if there's sort of, things are not progressing as planned, then I will, look into that at a certain time period in their recovery. Functional capacity evaluation is usually if somebody is taking longer than expected. So it's usually, many more months than a typical, shoulder or knee recovery, for instance. And I like them just because it's somebody's with them for many hours and putting them through many different tasks. And the therapists who we use for them, have a good sense of, is the person a straight shooter? Are they showing a good effort? Is there really an issue? And is there something else that needs to be done, or is there a permanent modified capability that they have?
Too, because they tend to be very detailed in all the areas, and sometimes have the opportunity to speak to the therapist too about something specific we might be looking at. So another good tool in the toolbox, as they say.
If every rotator cuff has a personality. Some people are 40 years old, have an acute tear, and there's nothing else going on in their shoulder. And they, some people recover very well. If you have arthritis in any body part and you're doing a repair or a ACL or a rotator cuff repair, and there's arthritis, the arthritis can act as a wrinkle. It can prolong recovery if someone's having pain from arthritis. We do the repair, but they still have arthritis, so that can sometimes cause prolonged recovery, dysfunction, swelling, soreness. Not somebody just cannot progress as quickly as somebody who doesn't have arthritis. And then you get into if this is many months after the repair and the repair's healed, but they still have pain or swelling or soreness from arthritis, then you can talk about a permanent partial restrictions going forward in the future. And I find that that's helpful with a functional capacity evaluation to see what's the max load that they feel comfortable lifting, that doesn't cause the arthritis pain.
That's good. And as you mentioned, every shoulder or rotator cuff tells its own story, as does every patient, treating them as an individual for sure. And as a vocational rehabilitation counselor, so I know that when I'm reviewing physician reports or medical provider reports, I'm looking at those notes to see also a progression. So especially post-op, if the doctor's making mention of, at the next office visit, we're going to talk about restrictions, or we anticipate a return to work within the next so many months, it's really helpful as a rehab counselor to kind of gauge when that time might be, to see if we're able to meet with that patient early to at least get the ball rolling, or if it's going to be, or anticipated, a prolonged recovery period. And I know in looking at those physician reports, that's something we definitely look at and consider. And then obviously when the doctor or medical provider gives specific limitations that we need to consider. Oftentimes my involvement or voc rehab counselor is typically when the claimant can't go back and do the work that they had, or that employer unfortunately doesn't have a permanent position, or they can't do the job that they had before.
Yeah.
Do you find that in your work, doctor, post-op, of kind of giving incremental steps, if you will, for that patient is helpful for them too, to be motivated or hopeful in that recovery process too, psychologically? Yeah,
no, I think the studies are pretty firm that getting somebody just back in their workplace, surrounded by friends, surrounded by coworkers, instead of sitting at home all day, is pretty much a very definite goal. And to get somebody just showing up, just doing anything, whether it's office work, phone calls, anything that, if they're a rotator cuff, or a knee replacement, just getting them moving, getting them in the not losing the habit of going to work. I think that's really important, and it's been shown to be, very helpful for mentally, physically, everything. And I think if you look at the studies that say, does someone like their job, that's also important. If somebody doesn't like their job, that's going to be a lot more difficult to get somebody to go back. But yeah, getting any kind of light job is always helpful if from an employer's point of view. For us, if we can say, 3 days a week, half days, start with that. And, paperwork, light duty work, walking around, checking things, guiding or instructing, like if they're an experienced worker, and then they can help train other people, showing young people what to do, like anything where somebody, acts as a supervisor, is, I find that always helpful. And then we'll take it from half days, 3 days a week to, full days, still light duty, full days, and then increase the strength. If it's a strength requirement, increase the pounds and the weights and the overhead activities or duration of standing and lifting and how much they're lifting. And, I want to see that same progression, stair climbing progression, gradually getting to the top.
That's a great point and a good segue. That was one of the questions I wanted to talk with you about too. Your feelings about gradual return to work, and I think those are great examples to see how they can progress physically through that, and also the mental health component. I find too that work is so much of all of our identities, right? And so it's what we've done day in and day out. Coworkers, bosses, and accountability, and being part of that employer. And so the longer that person is out of work, the less of their identity they see. So I definitely subscribe to that same kind of thinking. And I think it gives them the opportunity to try it, right? Try it without risk. So if you release the patient back a couple of hours a day, part-time, increase the days, the poundage as you suggested. And I think it gives them some confidence too, that they can do it. And a big part is working with the employers to see if they can allow that and provide something. And that's something I feel that the rehab counselor can be helpful, working with that employer to help identify positions that they might be able to do or make shift work that's meaningful. And has a sense of purpose.
Yeah, I think people are sometimes hesitant to go back to any work because they feel like they can't tell their employer, here are my restrictions. Like they come in with a piece of paper, and I think what I've seen is some employees are very nervous to do that because they feel like their employer is going to say, okay, you're back at work, this is what you're going to do, instead of what did the doctor say you could do. So I know that and I have a conversation with somebody and say, these are your restrictions, and you have to sort of be firm with your employer and say, these are what the doctor is allowing me to do. And if, that person is saying, no, you have to go lift 50 pounds and your restrictions are 5 pounds, you have to stick up for yourself. You have to say no. And I think that's helpful with a case manager and just having an employer who listens to the doctor's note is really important, because that's going to set up a good trust, as opposed to somebody saying, I don't want to go back to work because I don't know what they're going to tell me to do back there. So
right.
I find I have that conversation sometimes with people.
And we have had those experiences along the way, for sure. But I think in the last 20 years or so, employers are being much more aware of having folks come back to work, and that process is a much easier transition all the way around than having to find somebody else to fill the position along the way too.
Sure.
One thing I wanted to touch on too, you talked about light duty and light work, and that is a term of art, I know, in our field, and I think in your field as well. And I always scratch my head a little bit when I read physician notes that say return to work light duty effective a certain date, in a very general sense, without specific restrictions. And I wonder, what is that doctor thinking? So when he or she says light duty or light work, what does that mean? And I think if you put, 2 or 3 voc rehab counselors in a room, we may have a different definition, and perhaps individual physicians do too. But what do you find when you're releasing a patient to light duty work? What does that mean, or what do you hope that voc rehab counselor or that employer will do or implement from that perspective?
Yeah, I mean, if it's early on a, say, again, I think a rotator cuff is a useful example. If it's early on, I would expect that to be a very sort of walking around, light paperwork type thing. That say someone's going back at 6 to 8 weeks. And I always tell people, like, it's actually good, to start using your hands, and that helps lubricate the joint. And so light movements and range of motion is actually good, because you're not just sitting there with your arm stuck at your side. So light things, meaning, less than 5 pounds, no overhead activities, no prolonged reaching, and our note at Orthopedics New England is very specific, where we sort of, say, no prolonged activity, no prolonged overhead things, no squatting, no climbing, no reaching, no reaching above the waist. How much can you push? How much can you, lift? So we get pretty specific depending on, the body part. So yeah, at 2 months after a rotator cuff repair is, not stressing the repair. It's still healing, but getting that person driving, getting that person back to moving. And then, at 3 months, starting to, use it a little bit. Again, stressing it is helpful. To build up strength, and then hopefully by 5 to 6 months you've done that walk up and getting your muscle and your strength back.
And so, as a vocational rehabilitation counselor, in back cases too, looking at how long someone can sit, stand, or walk at any given time, at one time, and then throughout the day, and if they need a sit stand option, and how that might be interpreted from a quote unquote light duty release, and what that means, because, patients and clients coming to me will, much like you, will likely say, I can only, sit for 10 minutes and I get stiff, stand and walk for 5 or 10 minutes. And that's really helpful information that obviously impacts the types of jobs that they might be able to perform. And it could be on a preliminary basis too, or again, if proactively we're trying to get this client back to work and may improve over time, but things that we need to chat with the employer about along the way too. Do you find in those kind of knee patients and post-op back patients too about those postural limitations, and how does that fit into either a light duty release or specific restrictions that you often see?
Yeah, I think, building up endurance is the most important thing when it comes to the lower body, like, knee or hip replacements or back patients. Putting in, breaks every 10 minutes or breaks every 15 minutes, getting off your feet, rest for 5. Again, it's good if somebody, I always feel like if somebody's willing to get there and do it, then let the job, really accommodate, liberally right off the bat. And then hopefully as they get their confidence back up, that they'll start to return back to a normal, take a break every hour, once an hour, once every 2 hours, get off your feet. Starting off really slow is great, because it just gets somebody back in there. And then, that's not going to go on for months, obviously. And, but I think just getting people's confidence back and getting their muscles back in shape, it's anything is better than watching TV all day and sitting in front of the TV. Like, any little bit of movement, certainly any little bit of getting back to work is beneficial.
Great. And what do you see when it comes time to determine whether or not your patient can work, whether it's a gradual return or the claims adjuster may be asking if this patient's going to be able to go back to work? So let's take a nurse, for example, that had a knee replacement. If you're giving an opinion, if that patient can go back to work, do you typically give an opinion on whether, in this case, she can return to her past job that she was doing as a nurse when you say she's unable to go back or can go back? Or are you typically giving an opinion in general, no matter what is considered, and providing some specific limitations around that?
Yeah, I'll always say what kind of nurse are you? Are you a recovery room nurse where you're lifting and pulling and pushing people? Are you, an IV nurse where you're just putting in IVs? What does that mean specifically? Like, I like to know what's their maximum requirement that they're expected to do. Is it a psychiatric nurse where they sometimes have to get in and restrain people and get into scuffles with people who are need restraints, so that's important. But I will typically so if I say you may return to full duty, I'm expecting them to do that maximum job. If it is a light duty job, it's I'll start at just light duty and with specifics. So for me to say someone's going back full duty, I need to know, what the full requirements are. But I will gradually get them in a light duty capacity, whatever that light duty is for them. If they say I have to lift 50 pounds or lift, medicine cart, crates off the ground, that's going to be that'll be the final determination of, that sounds like that's going to be the biggest hurdle for them to get back to full duty. If that's that, you find out what the biggest thing they have to do is, and that's their full duty. But certainly, lifting 10 pounds, lifting 20 pounds, lifting 40 pounds is going to be the gradual return.
In one of the services that vocational rehabilitation counselors can provide are on-site job analyses. So sometimes the employer has a job description. Some are better than others. So some are more generic and some are pretty specific with those physical demands required. But vocational rehab counselors can go into the job site and actually observe the position being performed. You might take a machine operator, for example. All machine operators don't perform their positions the same way, right? So going in and observing, taking measurements, and looking at all of those postural demands, lifting, et cetera, that we can then present to a doctor. I think it's really underutilized. I don't think as many folks do it, but when it's in question, I would imagine that would be helpful for physicians to look at, to give that medical opinion to see whether or not the patient can go back.
Yeah, no, I always like to get as much information as possible. If somebody's can tell me what exactly is happening at work, if the patient has trouble doing that, or if a vocational rehab person can do that, that's great. The therapist, the employer, just let me know. It's always good to. I always will have the patient, and I'll show them the list of things, and I'll go over it with them, because we all, have all seen if a doctor just says, "Okay, you're good," and then just hands somebody a slip of paper, and then somebody calls back with questions and says, "I thought I told you," or I don't feel comfortable, so I will go over that with them in person. Like, I'll break out that piece of paper and say, I believe this is what you can do, and this is, you're safe. And, that's the most important thing, is that somebody's confident, safe, trust people. They don't feel like they're being, pushed into a situation that is dangerous or going to affect their repair or affect their outcome. I think once you gain somebody's trust and can have an open conversation with them about their work restrictions, then I think that's important.
I think you hit a good point, Doctor, about fear. That's what I see a lot too with the clients working with them. It's that fear of going back to work, and whether it's the fear their employer may not follow their restrictions or accommodate them, or a fear someone will replace them, or a fear that they're going to have more pain or do damage. And I think that that's a reality. And what I hear you saying is that communication between everybody, right? The physician, the patient, the employer, if they have a nurse case manager, voc rehab person, so that everybody's on the same page and so that that patient does feel safe and has that trust with everybody involved. That's a great point. Do you find that with vocational rehabilitation, if your patient is involved with someone like me or like us, that you have more confidence in releasing the patient back to work because someone's, in essence, looking out for your patient and making sure that the employer is working within their restrictions, and if they can't do their job, someone that's going to help them pivot?
Yeah, I think having that sort of backstop or that fail-safe, safety net, so to speak, where the patient feels comfortable talking to somebody and telling them, this, I did my functional capacity evaluation, and this is more than that, and having somebody who's just a spokesperson for them to have another opinion.
Oh, great. And what do you find? I'm always worried I'm going to take up too much time of a physician, and I know you folks are super busy, and the last thing you want are a bunch of letters and checklists, but it's the nature of the beast, I suppose.
Mm-hmm.
So over my career, I've kind of created different types of checklists, some shorter, some longer, and definitely the feedback is less is great, more is not. So getting to the point so that the physician has the time to actually look at the checklist, if that's something that's appropriate, to provide us as the voc rehab counselor with enough information to have an understanding of what that patient can and can't do. And some of the things that we see, especially with blue collar workers, is pace. So if they're working in a production environment, and if they're working on a conveyor belt and being able to keep up with that pace versus working at a work table, or anticipation that they might be absent from work from time to time because of exacerbation of pain or side effects from medication. If they go back to work 2-3 days and need a day off. What do you see with some of these checklists that I'm sure you've received that work and those that don't?
I like, a checklist that is 4 or 5 pages is tough. A lot of things too, I was just thinking about as you were saying it, it'd be easy if it was, say, an upper extremity checklist and then a lower extremity checklist. A lot of times it's mixed together, and so you have to sort of process that. And so it's if someone has a shoulder issue, just let's address the upper extremity. If someone has a lower body issue, let's address that. Like a rotator cuff repair, number of hours walking, is so I think that would be helpful if somehow the checklist could be broken up into upper, lower, something like that. But I think having it reasonable is certainly reasonable in my point of view. Now, how many times can you bend your index finger, and how many times can you bend your middle finger? Things like that. Sometimes they get pretty specific, but I think overall, reasonable checklists are certainly helpful. But I know what you're talking about with big long checklists that make it difficult to get through. People start skipping things, or they're not sort of processing all the different questions that are being asked.
Sure. Or the general ones that we might see that someone has as a form that they send to all the medical providers, as you said, not really applicable to the body parts that you're focused on with your patient.
Yeah.
And doctor, one thing comes to mind too, we've talked a lot about post-operatively and preparing that patient to return to work. What about pre-operatively? Kind of the mindset of the physician talking to the patient. Obviously, you're going over the risks of the procedure and the outcomes and what you hope for in terms of improving functionality and decreased pain. But any discussions with the patient beforehand about expectations of return to work also?
Yeah, no, absolutely. I think that's part of decision making, is somebody needs to know what is coming up in the future for them, and what, just to be able to plan their life and plan their job and to be able to tell their employer what they're going to be going through. So I do have a sheet here of commonly asked questions that I always sit down and fill out with somebody, and it goes through when can someone drive, how long in a sling, how long on crutches, and then how long out of work. And I think that sets the table for 6 weeks from surgery, you're going to be back at work, doing something, just showing up, light duty, say. At 3 months, you're going to be advancing. And then at, say, 4 to 5 months, you're going to be full duty. And that's the expectation. And I think if someone has that in their head, and if an employer has that, then, everybody can plan accordingly. I think more information is better, especially preoperatively when you're, so there are no surprises after surgery.
I think that's great. I'm happy to hear that you do that. I know other physicians do as well. And I think it's helpful. Again, I keep talking about that mental health component, but it's very real. And I think that for patients to, again, have hope, and it takes away some of that ambiguity of, am I ever going to go back to work? And what if I don't? But rather setting the table and setting the tone, as you mentioned, that this is the expectation and we will get you there. That's what we all anticipate. And they have that in their mind going forward, as opposed to what's going to happen in 6 months or 8 months or a year. I think that's really important.
Yeah, I know people will come in afterwards and they'll say, am I ever going to go back to work? And I'm like, well, yes, next week, or next 2 weeks, I'm going to write you a note that's going to let you get back to light duty. And they sort of forget sometimes the questions that we discussed pre-op. But I think it is helpful. More information is better.
Great. Well, thank you, Doctor. I think that this was a good exchange in learning more about the physician's perspective on return to work efforts.
Thank you, Kerry and Dr. Rockett, for being with us today for such a robust discussion. And thank you to our listeners. Please visit our website, medicalandlifecare.com, for more information on vocational services, case management, medical legal services, our Injury Insight webinars, and more. If you're interested in featuring on our podcast, please email our office at info@medicalandlifecare.com.